Good morning, students. I'm Dr. Dharani. I'm going to start a new system from today. We will be dealing with the gastrointestinal system. So this will be my first class. So it will be regarding the approach towards a patient with the gastrointestinal disease. So before that, I highlight something regarding the anatomy and the physiological part of GIT. So we all know it extends from the mouth to the anus, and it's composed of so many organs with distinct and different functions. So in that path, it carries so many sphincters that assist in a gut compartmentalization. It separates the organs. The gut wall is organized into distinct layers that contribute to the regional activities. Here, the mucosa is a very important barrier to luminal contents or a site for fluid and nutrient transfer. The smooth muscle, which helps in uh, the mechanism of absorption and the transfer, which is in association with the enteric nervous system, mediates the propulsion from one region to the next. These are the main functions. Mainly, the GI tract helps in assimilating nutrients and eliminating the waste. In the mouth, food is processed, mixed with the salivary juice, that is amylase, and delivered into the gut lumen. The esophagus propels the bolus into the stomach. The lower esophageal sphincter prevents oral reflux of the gastric contents. The special squamous esophageal mucosa protects against the significant diffusion of the absorption of the contents. These in the esophagus, the contraction present in the esophageal area, which coordinate and with the relaxation of the upper and lower esophageal sphincters on swallowing. The stomach triturates and mixes the fluid bolus with the pepsin and acid. This gastric acid also sterilizes the upper gut. The proximal stomach serves as a storage function by relaxing to accommodate the meal. And one more important function of the stomach is the absorption of vitamin B12 with the help of an intrinsic factor. The most of the nutrient absorption occurs in the small intestine. This triturated food from the stomach mixes with the pancreatic juice and bile in the duodenum. We all know this pancreatic juice contains so many enzymes which helps in the mm, digestion part of the carbohydrate, protein, and fat, as well as this bicarbonate to optimize the pH for enzyme activation. Bile secreted by the liver and stored in the gallbladder, which is essential for the lipid digestion. The proximal intestine is optimized for rapid absorption of most nutrients and minerals, whereas the ileum is best suited for the absorption of vitamin B12 and bile acids. Next, if you go to the colon, this prepares waste for evacuation. This colonic mucosa dehydrates the stool, decreasing the volume of the content from 1 to 1.5 liter to the 100 to 200 ml, which is expelled from the rectum. The proximal colon mixes and absorbs the fluid, while the distal colon exhibits the peristaltic contraction and mass movement to expel the waste. So coming to the approach, before approach towards a GI system disease, we can divide or classify the gastrointestinal diseases into these subheadings. That is, number one is the impaired digestion and absorption, altered secretion, altered gut transit, immune dysregulation, impaired gut blood flow, neoplastic degeneration, disorders without obvious organic abnormalities. The last one is the genetic influences. First one, this impaired digestion and absorption means, for example, this can be This impaired digestion and absorption can be in the stomach or in the intestine or in the biliary tree or in the pancreas. Most commonly, like maldigestion syndrome, lactose deficiency, okay, which produces a large gas and diarrhea, okay, and some kind of celiac sprue, bacterial overgrowth, Crohn's ileitis, okay, and these are the examples of impaired digestion and absorption, okay. Second one is the altered secretion. In that, some gastric acid hypersecretion syndromes like Zollinger-Ellison syndrome, or some of the individual cell hyperplasia like G cell hyperplasia, okay, and some of the ulcers which will produce excessive acids, okay, and some of the atrophic gastritis will also come under altered secretion. And if you go to the altered gut transit, it can be in this classification. There will be conditions like gastric outlet obstruction, in that a small bowel obstruction, or it can be due to so many adhesions, or celiac disease, or some due to radiation exposure, some may be related with the malignancies, okay. And if you go to the immune dysregulation, for example, in celiac disease, there will be a immune dysregulation associated with mucosal inflammation, and some conditions like in celiac disease also there will be a which results from dietary ingestion of gluten containing grains, which leads to immune dysregulation. And in ulcerative colitis and Crohn's disease also there will be a dysregulation of the immune system. And if we go to the impaired gut blood flow, like there will be some mesenteric insufficiency, or in celiac disease also there will be a gastroparesis result from blockage of the celiac and superior mesenteric arteries. And if you go to the neoplastic degeneration, where are various carcinomas starting from the esophagus to the um, lower lower end, and disorders without obvious organic abnormalities. In this, we will be dealing with the irritable bowel syndrome, and some of the functional dyspepsias and functional heartburns, okay. And in the genetic influences, so many other diseases will be there, like inflammatory bowel diseases, and some of the even malignancies can be associated with the like pancreatic malignancies, colonic malignancies, and these will also have a genetic influences over the GI diseases. So these are the common symptoms and signs we usually come across when we evaluate a patient of gastrointestinal tract. The number one is the dysphagia, which may or may not associated with odynophagia or heartburn. Second one is the nausea with or without vomiting or retching. Dyspepsia, abdominal pain, gastrointestinal bleeding, constipation, diarrhea, and the weight loss. So sometimes in exam they may ask regarding the causes or the classification of the this dysphagia or the other kinds of abdominal pain, based on maybe they may ask something regarding the quadrants of the abdomen, and they may ask you the different types of abdominal pain and the nature of the pain also. So next, coming to the dysphagia, it's a difficulty in passage of solids or liquids from the mouth to the stomach, whereas odynophagia means which is painful swallowing. Heartburn is just a burning sensation behind the sternum. Basically, if these three symptoms presents, basically we have to suspect maybe a patient might be having a problem in the esophagus. esophagus. So this dysphagia can be divided into proximal, based on the anatomy, proximal esophagus or the lower end of the esophagus. So left side will be highlighting regarding the upper or the proximal. The right side will be the distal end. So in the proximal or the oropharyngeal dysphagia, which will be associated with the neuromuscular mechanism of the pharynx and the cricopharynges. Here, patient is unable to initiate and execute the swallowing mechanism, and these patients may be associated with coughing and regurgitation of the fluids, and sometimes they may have associated with cranial nerve palsies in the. So these patients may exhibit symptoms of dysarthria and hoarseness of voice. For example, if we take this neurological examples like strokes and motor neuron disease, Parkinson's disease, multiple sclerosis, and myasthenia, if only the anatomical involvement due to the pharynx and the cricopharynges, maybe due to oropharyngeal malignancy involvement and Zenker's diverticulum and retropharyngeal abscess. This lower esophageal dysphagia will be involving the body of the esophagus and the gastroesophageal junction. In this, examples are like achalasia, scleroderma, Chagas disease, diffuse esophageal spasms. If it is just a mechanical obstruction, it could be due to esophageal webs, Schatzki's ring, neoplasms, and the strictures. So any patient comes with a dysphagia, if he is able to initiate a swallow, or if he is not having a nasal regurgitation and or coughing and other things, and coughing or on swallowing, then maybe we are dealing with the lower esophageal dysphagia. Then in that we have to ask whether he is having a dysphagia to only to solids or just like and never liquids alone. Then it might be and associated with weight loss and which is having a long standing history and with the heartburn. Maybe we are dealing with the mechanical obstruction. If the patient is having both for solids and liquids and with bland regurgitation of undigested food, as like in achalasia, and some of the manures like Valsalva and rising arms, and if the patient is feeling little relieved, we might be dealing with the patient of neuromuscular disease. Okay, if patient having a difficulty in initiating swallow with nasal regurgitation or coughing on swallowing, we might be dealing with the patient of oropharyngeal dysphagia. So the second symptom is nausea. It's a nausea means is an unpleasant feeling of wanting to vomit. Few times it may be most of the time it will be associated with the autonomic symptoms like increased salivation and sweating. Retching is a strong involuntary effort at vomiting. Vomiting is associated with bringing out the stomach contents. These are the different causes, infections like cholecystitis, pancreatitis, infectious, any infections involving the esophagus, stomach, and up to the lower esophageal sphincters few times, and the lower GI tract also. Second one will be the bowel obstruction. It's very important when we come across with any patients with bowel obstruction. Typically they will be having a vomiting, and the peptic ulcer, drugs, motion sickness, and raised intracranial tension, where they will be having a projectile vomiting. Projectile vomiting means they won't be having a associated with nausea, meningitis, azotemia, pregnancy, or in some of the systemic illnesses. Okay, as we know, here in raised intracranial tension, they won't be having a nausea, so patient will spontaneously vomit. In gastric outlet obstruction, there will be a stale food in vomitus, whereas in the vomitus will be bilious in obstruction to distal to the duodenum. Whereas if the vomiting is due to some psychogenic causes, the patient will vomit soon after a meal. So next, coming to the dyspepsia, in dyspepsia means the patient will complain of very kind of complaints. Some patients will tell bloating sensation, or after having food they will feel like increase in the size of the abdominal girth or the fullness, and some patients will have heartburn and belching. Okay, it's basically defined as a chronic or recurrent pain or discomfort centered in the upper abdomen. Okay, any patient who presents with all these symptoms, if they're having these above mentioned symptoms, then you should be very cautious in dealing with these patients. Okay, because this may alarm towards the other systemic or significant illness of the GI tract, like anemia, weight loss, GI bleed, whose age more than 45 years, dysphagia, and recent onset of progressive symptoms. This may suggest like we may be dealing with some of the carcinomas or the chronic conditions. The other symptomatology is the abdominal pain. This pain nature can be divided into visceral, parietal, and referred pain. This visceral pain is usually dull, crampy, which is poorly localized. Usually this will be in the midline because the abdominal organs transmit afferents to the both sides of the spinal cord. Here we can look at the pain which corresponds to those dermatomes. So pain from abdominal organs proximal to the ligament of treats is felt in the epigastrium, which is from ligament of treats to the between the ligament of treats and the hepatic flexure will be felt in the periumbilical region, which is behind the hepatic flexure will be perceived in the lower abdomen or midline. The second nature of the abdominal pain is the parietal pain, which is well localized, sharp, which will be due to the inflammation or the irritation of the peritoneum. Example like appendicitis. This referred pain in cases of liver abscess causing diaphragmatic irritation. These patients may experience a pain in the shoulder region. So this is the nature. For example, in patients with peritonitis, they will just lie still, and if you're going to examine, they'll be having a tender and rigid abdomen. Okay, but in contrast, if the in patients with just involvement of the ureter, only that passage or the small area, maybe due to the stones or due to any infection, they will be having a very severe pain, and they will be rolling on the bed because of that excruciating pain. So next, one of the very important symptom is the gastrointestinal bleeding. In this, there are three subheadings. Okay, melena, hematochezia, and the hematemesis. Okay, if patient is having both melena and hematemesis, okay, then possibility of upper GI involvement will be there. And if patient is having only hematochezia, then we may suspect there might be a lower GI source. Okay, melena means it's a black, tarry, foul-smelling stool, and usually it signifies more than 15 ml of bleeding might have occurred to come this blood in a stool. Okay, usually it takes some 12 hours of transit time to develop. Hematochezia means it's a maroon bloody stools can come from a proximal GI source also in if the intestinal transit time is more. Okay, usually signifies lower GI source. Fresh red blood is commonly due to rectal or left colonic disease. Okay, hematemesis means blood in omitus. It may be fresh bright red or older coffee ground material. As we know, it signifies the upper GI source. So we have to any upper GI bleeding, we have to differentiate whether we are dealing with the variceal bleeding or non-variceal bleeding. These are the differentiating points. In variceal bleeding, like these patients will have signs of chronic liver cell failure and jaundice and ascites, splenomegaly, and maybe they might have undergone some treatment for liver disease in the past. Non-variceal bleeding will be like they might be using NSAIDs for longer time, and they might be having a past peptic ulcer, and they have a typical epigastric pain and recurrent vomiting and retching. So next symptom is the constipation. Typically these patients will complain of passing hard stools, and they need they strain for a longer time, and they will have a sense of incomplete bowel evacuation and excessive time spent. And we can divide this in terms of they pass usually less than 3 stools per week. This is a very common symptom in elderly. So even though some of the drugs like calcium supplements and iron supplements may aggravate the constipation. So any recent onset of constipation with or without the melena or the hematochezia, it raises a possibility of a malignant lesion. So next important symptom is the diarrhea. It's defined as increase of volume, frequency or fluidity of stool. It could be acute or chronic. In acute means it within 4 weeks, chronic means more than 4 weeks. So if it is acute diarrhea, it could be due to infections and toxins, okay, and usually associated with the signs of infection and inflammation. And chronic diarrhea is usually associated with malabsorption and weight loss. So these are the, if some patients are having chronic diarrhea with all this symptoms or the signs when you're going to examine this patient. If patient is having a chronic diarrhea with clubbing, you may suspect chronic or immunoproliferative small intestinal diseases, and like celiac disease, Crohn's disease. Okay. If patient is having a fever with chronic diarrhea, you have to first in our subcontinent you have to think in terms of tuberculosis, Crohn's, Whipple's, other ulcerative colitis. If patient is showing improvement to the antibiotic, we may be dealing with a bacterial overgrowth or tropical sprue and giardiasis. If patient is showing some response to steroids, we may be dealing with an inflammatory bowel disease or eosinophilic gastroenteritis. If patient is having a chronic diarrhea with arthritis, maybe IBD, a celiac disease. If patient is having a chronic diarrhea with lymphadenopathy, number one is the HIV. Okay, and sometimes we may be dealing with the tuberculosis also. Okay, these are the different things like dermatitis herpetiformis in celiac disease, pyoderma gangrenosum in inflammatory bowel disease. Abdominal mass with chronic diarrhea means some of the lymphomas and Crohn's disease and in tuberculosis also. Um, it's just one slide which is showing the differentiating features from inflammatory bowel syndrome. Irritable bowel syndrome. Um, if patient is having a fever, weight loss, and nocturnal diarrhea, blood in stools, decrease in hemoglobin, elevated ESR, so we may not be dealing with a irritable bowel syndrome. So this is one slide which is showing some differentiating features from the large bowel diarrhea and the small bowel diarrhea. They may ask this in short notes. So in large bowel diarrhea, usually this will be associated with presence of blood and mucus, and they will be having a rectal symptoms like tenesmus and dyschezia, and they pass small volume jelly like stools and associated with the hypogastric cramps in the lower abdomen. In small bowel diarrhea, the will be floating, greasy, and containing undigested food particles. And usually, this small bowel diarrhea will be in large volumes. The pain will be situated over the mid-abdominal regions with borborygmi. So, any chronic diarrhea, like here in this slide, it is showing first we have to rule out the IBS for that, and then we'll divide into whether it's going for a large bowel or the small bowel. If patient is having some malabsorption kind of things, then you have to work out for that. Okay, then you have to, after malabsorption workup, you have to think whether patient might be having any pancreatitis features. If it founds to be negative, we could be dealing with a water diarrhea. Okay, in large bowel diarrhea, after the evaluation, you will go for a colonoscopy. If colonoscopy founds to be negative, then we might be dealing with a water diarrhea. Then next we have to do the fecal osmotic gap and response to fasting, and sometimes we may need to go for the biopsy. So this is the last symptom. It may be physiological, like in dieting, exercise, and starvation. But if the weight loss is more than 3 kg over past 6 months, it is a significant thing. So these are the different causes of weight loss. We are not just, I have not mentioned only the GIT causes. All system affection can cause weight loss. In GIT, maybe due to poor dentition, malabsorption, malignancy at different levels, inflammatory bowel disease, okay, chronic infections like tuberculosis, HIV, and in cirrhosis also. Okay, and in cardiac conditions like congestive cardiac failure, infective endocarditis, in renal like chronic kidney disease, occult malignancies, in respiratory COPD, pulmonary TB, and carcinomas, endocrine in diabetes mellitus, thyrotoxicosis, Addison's disease, in Parkinsonism and dementia, motor neuron disease, and some of the psychiatric conditions like depression, bipolar disease, okay, and in alcoholism. So this this first class finishes the symptomatology. So if any doubts, contact me. Thank you.